Press the button. The button.
Should be working?
Hello.
Yes.
Okay, fantastic. Good evening, ladies and gentlemen. My name is Sudarshan Pillay. I am the Wits Students Surgical Society's head of events. And on behalf of the society, I'd just like to welcome you all tonight and our in-person audience, our online audience, and then last but not least, our dear speakers. You know, this is the Great Debates. It's our annual, most highly anticipated event where we have surgeons that represent different specialties essentially battle for the title Speciality Supreme. And guess what? It is you, the audience, that will be deciding who that Speciality Supreme is. A vote will be done towards the end. So I do recommend that you listen intently, but also enjoy yourselves. And then when the time comes, you can just vote for who you think deserves the title of Specialty Supreme. There is a QR code that's going to be placed in the front, and you can just scan it, and you should receive the digital program for tonight as well. So how tonight will work is that there'll be 3 rounds, and essentially, before each round, our host will essentially explain the rules and proceedings for that round. And on that note, I'd just like to welcome up the host for tonight. It is the Wits Students Surgical Society's very own Vice President, Dominic Costa. And yeah.
Goodness gracious, I didn't think I'd get any applause. Whew. Kind of wish I got some applause after that endo exam this morning. 4th years will understand what I'm talking about. All right. Welcome to the Great Debate. It's so great to have everyone here in person. Goodness gracious, the past 2 years we've been sitting there watching people insult each other on our cell phones. I've been sitting in the dark like Peter is now, staring at the screen being like, is the stream working? Are we behind? The speaker's talking a bit long, aren't they? So I'm very glad we can be here and insult each other in person, because I think face-to-face is a lot more personal. We can get a lot more personal, right? Awesome. So let's get on with it. So we're going to start with the first round. So let's see what we told the speakers to speak about. So this round is an introductory round that will allow every speaker to introduce themselves. Their presentations will include a brief introduction of themselves, an introduction of the speciality they represent, studies, inspirations, and that led them in their decision to pursue their speciality, what a day in their speciality looks like, and the reason why they are the best and better than the rest. Wonderful. So before I introduce our lovely speakers, or not so lovely as you'll find out in a moment, just some housekeeping rules. It sounds like I'm in a pantomime, goodness gracious. So if everyone could maybe turn their phones on silent or on Do Not Disturb. Doctors who are more advanced in age, if you could turn off your pages. I'm sure no one will die while you're here this evening. Please. All right, maybe I'm part of this debate too, goodness gracious. So, without further ado, let's introduce in no particular order. They actually decided this order. We're going to start with our, well, actually, let me list all of you first. We have Dr. Timothy Haji-Joannou. Yes, got that right. We have Dr. Siseko Gqola. Yes. Dr. Bodhi Chakraborty, Dr. Francisca van der Schyff, and last but not least, well, we'll find out maybe, Dr. Alex Diakakis, representing neurosurgery, gynaecology, trauma surgery, transplant surgery, and plastic surgery. I remember that all by myself. Awesome. So without further ado, I think we'll start with Dr. Haji-Joannou. If you could come up and let the bloodbath begin.
Yeah, where do I have my presentation? Come up here, eh? Oh, it's actually here. Okay. Will you give me a head? Go ahead. Yo. Wow, it started.
That's the spirit.
Okay, you're going to give me a head when to start, right?
Yeah.
Yes. All right, cool.
There we go.
All right, neurosurgery, the greatest specialty ends out. Should I just walk out of here now because, let's be honest, it is the greatest. All right. Usually I'll start off with a joke, but I guess the presence of trauma surgery is the joke right there. Okay, so let's start. Let's a quick introduction to myself. Next slide. Is there a tab? I think there's a thing. Okay, there we go. All right, I'm Dr. Timothy Haji-Joannou. Essentially, I'm a Wits graduate from 2016. I essentially did my internship at Schyff Hospital. I had a 6-week rotation in neurosurgery, got exposed to giants in the game, Prof. Agachi, Prof. Graham Fegan, etc. Fell in love with the thing right there. Already knew that I don't have to do any relooks for the rest of my life. And then went on to do my community service at Tsapong Hospital, and then started at the Chris Hani Baragwanath Neurosurgery Unit in 2020. Ultimately got 4 years exposure to neurosurgery. So, what is neurosurgery? Most of my colleagues here, they'll think it's just about, her head a bed at 30 degrees, some neuroobs, phenytoin. I think they don't even know the dose of phenytoin. Mannitol, gynae. Mannitol makes... Huh? Okay, there we go. Mannitol, gynae. Mannitol makes you wee-wee. Wee-wee, brain less swelling. Okay, all right. And let's move on, and then not for neurosurgical intervention, but it's more than that. 90%. So what is neurosurgery? Well, it's a discipline that focuses on the diagnosis and treatment of disorders of the brain, spine, and peripheral nervous system, including its vasculature. It's the first and foremost a surgical discipline that requires significant knowledge of neurology, critical care, trauma care, and radiology. And ultimately, it is essentially there to optimize neurological function through brain and spine surgery.
It's good Wikipedia.
Okay, so neurosurgery essentially involves multiple subspecs: trauma, neurocritical care, cerebrovascular, functional, neuro-oncology, skull-based, pediatric, spine. We have a lot going on for us. All right, trauma, most of these guys think they know it. Trauma surgery, not much. All right, we see subdurals, we see extradurals, we see fractures, we see gunshot heads. The percentage that we see, usually neurosurgery, specifically at Barra, sees a large percentage of trauma, and we know how to deal with it. All right. And then neurocritical care, so that's a party, let's be honest. It's critical care, but a lot deeper. We have our cerebral oxygen monitors, we have our intracranial pressure monitors, EVDs. EVD, external ventricular drain. Okay, right, there we go. Microdialysis catheters and a repeat CT brain. You know that's usually 72 hours when we ask you. All right, and ultimately a holistic management of patients, not continuum management, etc. All right, cerebrovascular surgery, we deal with our aneurysms, arteriovenous malformations, strokes, our fancy ones like dural AVFs, and it's ultimately a clean surgery. There's no sewage pipes, there's no poo anywhere. Okay, and then our functional neurosurgery is our sleek and sexy vibes. Yeah, we're going to tech savvy. We look at our epilepsy surgery, a deep brain stimulation, rhizotomies, we ablate some nerves to help, and it's essentially the future of neurosurgery. And then oncology, we look at our intrinsic brain tumors. We either biopsy them, debulk them, completely resect them. And essentially, we look at our tumor biology to decide whether or not they should go to oncology. All right. And then skull-based surgery. Now this, you want to bamba. You want to roll with the big boys. You better run, giddy. All right. Essentially, this deals with pathology, mainly tumors involving in any part of the skull-based surgery. So people with balls will do this. All right. We look at our meningiomas, pituitaries, anything that's around cranial nerves, brainstem, our ICAs, all of that. And then spine surgeries, our orthopedics. Of neurosurgery, more hands-on, minds off. We look at trauma, degenerative tumors. This is all, some posterior fossa decompressions for our Chiari malformations. Eh? And then pediatrics. It's essentially neurosurgery, but smaller. Shout out to our myelomeningocele, hydrocephalus, and TBIs, and all that other cool stuff. Okay, so what is the day in the life of a neurosurgeon? So, early mornings, we work for, hard work for about an hour, morning meetings to account for our sins for the night before. Coffee before patients, coffee before life, coffee before our wives. All right. So essentially, then we go off, we go save some lives in theater, and when we're done, we go home.
Don't drink coffee.
All right, so what are the pros and cons? I just want to emphasize on the right. We make money. All right. If you translate, that's 12 million rand a year. All right. So let's get that. And okay, so we treat the sickest patients. You become smarter. Okay. There's variety. We know there's just unlimited medical research opportunities, and once again, best smelling surgery. Cons, we can ignore that. Let's be honest, pros are better. All right. Thank you very much. How much time do I have left?
Just keep going.
Eh? Okay, so we might as well do a bit of stand-up comedy, yeah? All right? Okay, so how do you hide money away from a trauma surgeon? You hide it in the patient's file. How do you hide money from a plastic surgeon? You can't, let's be honest. And then how do you hide money from a gynae? Above the umbilicus. Okay, all right, thank you very much.
I think your friend may have stolen it.
The clicker. Never mind. Clicky, yeah?
Hide it in the file.
Those are fake glasses, by the way. Loved her.
Computer's a bit slow. Apologize.
No stress. Hey. How's it, guys? I think this is my presentation. I'm Bodhi. I'm a second-year general surgery registrar. One of my main fields of interest is in trauma, hence I'm representing them. So I used to be, well, first of all, it's really great to be amongst great guys. I mean, and all surgical specialties are amazing. We all work hard. So mad respect to everyone. Except for neurosurgery, gynae, plastics. And I'm hoping they got a transplant next, so I'm not really going to dig there. Okay. Okay, so...
Catfish.
So, proof you can have it all. I'm anticipating some digs at trauma surgery or general surgery in general, saying that, you know, we definitely have the worst hours, but you can clearly have it all. That's me in the day or nights. That's me in the operating theater. So you can have it all. But just in general, I mean, everyone here, you guys are all students. You all go partying, I'm sure. So someone in Brom, outside, I don't know where you go nowadays, but someone just got stabbed. What's the guy you're gonna do? He's gonna run away. He's gonna run.
Who is doing the stabbing?
He's headed to Rima Musa. Tim, as you rightfully said, is gonna rock him up at 30 degrees. Job done. Transplant's gonna wait for him to die. Trauma patients are the best candidates, young, so she knows it's true. Plastics is gonna close it real nice. He's gonna be bleeding in the inside. So in general, trauma saves the most lives. And I mean, that's why all of you guys did medicine in the first place. You can see all the sparkly eyes. You're here after hours. You could be home chilling, watching Netflix or going out, but you're here watching doctors talk. So you do it because you love surgery and because it's something you want to do. So surgery, trauma surgery specifically, you'll be saving the most lives, absolutely. There's no debate there. So these are just stats from Barrow and Millpark put together. We see everything. So head to toe, there's nothing we really don't do. Patient comes in through resus, whatever the pathology is, we assess them, and you guys also help us with that in the pit. And you assess the patient, and whatever the pathology is, whatever the trauma insult is, it's your job to sort it out. Everyone else here comes in afterwards. It's a fact. So in terms of sheer volumes of lives saved, that's us. There's more stats. You'll learn that later. So why trauma surgery? So I cut the face off for the patient's identity, but it's a thoracotomy that I did, or stenotomy, thoracotomy and then stenotomy on a patient, stab hearts. And then you get to see these patients walk out grateful for their lives, and you know you're responsible for that. Does the video play? So you just see if you can...
No, that's about quick piece.
Yeah. So I mean, it's the only other field really that we have that's you're not just in hospital, you're also in the field. So later on in my presentation, I'll be talking about more specific things. But we're the ones that go out in the helicopters. We're the ones that amputate arms out in the bundus. So the other specialties don't do this. Okay, I'll wait for it's a long video, and I don't have that much time. This is your resident neurosurgeon. So as a reg, so look, I can, from experience, I've done a lot of things in trauma surgery. I've sutured hearts, I've done laps, you name it, right? Vascular repairs. There's Tim assisting his consultant. Caught him red-handed. Just blurred out the middle finger there. The other half of Tim's calls is that. He's just fast asleep. You phone him, you send him a CT scan, not for neurosurgical intervention.
There better be no more photos. The patient in the
You click versus us working, doing our job. And I know, like I said, I know what they're gonna come at for trauma surgeons. You're a consultant, you're gonna be working for the rest of your life. You're gonna be 65 years old at Barrow doing the calls. But I mean, it's a lesson for life. You never stop working. I don't think anyone here wants to have a comfortable retirement. You want to be practicing your... So, no, you're telling me you spent all those years of investing a skill and talent to then just let it go away. You can go and operate, and then you can be on call. You can obviously still go on holiday and go to your boat or whatever it is you want to buy. And then, fundamentally, trauma surgeons are leaders. So I challenge any one of... Okay, not transplant. But I challenge my other colleagues here to make Barrow trauma look like this. I'm sure any of you walk in when you're students, you're going to look at this and panic. And that's it. And then the next day, to make it look like that. That's us. It takes leadership, it takes hard work, it takes teamwork, and it's something that we all proficient at. Some of the sub-specs, not so much teamwork. Just saying. Yeah. And then, as I mentioned earlier, this is data that's out there. We're the only field that's actually out there doing things. We go in helicopters, we go... What? Don't say it. Okay. So amputations and all sorts of things you can do out in the field that, unfortunately, you can't really drill. Well, I suppose you could drill a hole in the brain in the field, eh? Yeah. And the other thing that McDreamy hasn't told you about is this is SA. So 90% of the trauma or what the neurosurgeons see and get their fancy paychecks for is craniotomies from trauma, which is essentially a brain IND. So, yeah. Okay, and I was just going to say, this is our boss's new car. So the whole money, so WhatsApp. So you can have it all. And I'm sure none of you are here just for the money as well. But if that is part of it, the appeal, then there you have it too. Okay, well, that's my introduction.
Good evening, everyone. I guess these guys really work at emergencies. We were told, introduce yourself, say what you want to do in the future. We'll see all of this in the second round. I'm not happy. Anyway, my name is Dr. Gqola. I'm a gynae. I'm a consultant currently at Tele Mukhwarane Hospital. I want to talk about this in the second round, so I'm just going to keep the first slide there. I'll proceed then. If you want me to proceed, okay. Thank you. Guys, if you want to know futuristic surgery, my last slide, I'm going to speak about individuals that were trained here in this institution that are doing great stuff within our institution. I want to be a gynae oncologist, but for now, I think I'm enjoying being general gynae. What do I do? Oh, press here, yeah? So Umandla, let me start there first. Umandla, happy Women's Day. Everyone who's here, yes, I know. Even these guys that are chappy here, I know that when their wife, their daughter, when something's wrong, for the first time, they're so nice to you. That, oh, Dr. G, yes, we know you're the greatest gynae ever. Thank you. Yeah, yes. Everyone comes to us. When I heard it was a debate, I was so sad because I was like, no, I work with pediatrics, plastic surgeons, I work with them nicely. They come to help us. Okay, neurosurgeons, no, never. General surgery, yeah, I get to call them. I'm like, that left iliac fossa, it's not me. You need to assess that, it's the appendix. It's like, no, it's not. It is you. I'm like, no. But I work with everyone, so I can't fight everyone. But anyway, guys, in our surgeries, we've improved so much. Like looking at minimally invasive gynecology surgery, we've been, I think, improvement in gynae oncology, fertility surgery, fetal therapy that I'll speak of. One of the guys, first in Africa, surgery that was done, which was a fetal surgery that I'll speak about. The future, if you look at the future, you'll be sleeping at home. Now, what they've been telling you that you stay awake because of cesarean sections, it's not true. We're going to have these guys, they're doing this for us. You'll be sitting at home pressing a computer and you'll have fun. So come to gynae, I'm telling you. So looking at this, what's interesting, it was the gynaes actually that started putting a camera within the abdomen to see what's happening there. Why leave a scar there? The lady must not have anything, but you should have done the best surgery within there. So we offer so much that looking at removal of fibroids, endometriosis, ovarian cysts that we do, and no scar. I'm telling you, I don't even need the plastic surgeon anymore. Because now, those wounds, those big wounds that these guys are doing there in trauma, you come back like, please, plastic surgeon, this guy is so nice. She wants to travel to Dubai. No more. We use the camera. Right? So we look at gynae oncology. Yes, this one, we are going to definitely need our plastic surgeons there because our wounds are quite big for these surgeries. But we get to enjoy so much surgery. This is the area that I want to go into and specialize into. Many procedures that we do, we will do endoscopy surgery that assists quite a lot of women that have challenges with having to help their families. And we know there's so much pressure in SA around the world, that how you set up your family, how everything goes. We even judge you based on how many children do you have. We judge you with who's your boyfriend or who's your... If you don't, it's like, you're excluded in society. So I'm there, Dr. G. I'll make sure that you enjoy everything. Enjoy your relationship. So I'll make sure. So when you're looking at advancement, we've gone now not just into the abdomen, in the uterus. Oh, I'm telling you, no scar. Get to do all the surgeries he's talking about. I was like, no, the mother's been involved in abdominal surgery. The baby's probably, I'm like, how's the baby? No, he calls me, he's like, yo, come see the baby. I do my endoscopy. The worst is busy with the heart, the brain, and what, checking how's the baby there. Okay, continue that brain surgery there. No, the baby's fine. The baby's fine. Do not worry. And don't know if anyone knows of this case. One of our professors, the Professor Nicola, he's at Wits. Thank you. He trained me, and now I've joined the boy walk as well with pride. That yes, I'm the greatest gynae. So what they've done, there's a family that that noted that one of the during an ultrasound scan that the baby had spina bifida, which is an abnormal development, which opens. So you find there's an opening of the spine into the amniotic fluid. There is a problem because already the nerves, it will have an effect on how the lower part is supplied by the nerves. So they did find it. One of the why is it off? Oh, sorry. Yes. So this is a story of, I'll use the name, I didn't get permission from the family, but I will use it kindly. It's called the Miracle Baby. It is baby Kate in Pillay. So the great family gynecologist was there. Oh, nice, congratulations. Oh, you guys are, with all the money that you saved, are you guys ready? As they were scanning, they realized that something is not correct at the spine where it was not closing correctly, which then it was a feature that sign of spinal bifida, of which the severe form that baby Caden had, of which it was a myelo meningocele. So you can imagine how devastating that is for that couple, for that family, the uncles, everyone who's involved, who's supporting and happy for them that there's a baby. That I think when they found this diagnosis, it was when they were doing a fetal anatomy scan so it was at 20 weeks when they noted that diagnosis. So you can imagine Mrs. Pillay there. I think it's the cousin of the family there. Mrs. Pillay and Mr. Pillay, confused and undecided, they were referred the very next day to a specialist for complete understanding of the condition, of which Professor Nikolai was there, works at a medical clinic in Morningside. So teaches and as well as trains South Africans, especially the maternal-fetal medicine department. So he's a maternal-fetal medicine surgery expert, of which he trains under the Wits institution. And another guy, he had a team that was coming all the way from the States, which was led by Professor Michael. I had a chance as well to spend with him for 3 months, teaching us. I think 2019 was the registrar at that time. So he also received his degree here. So it means that if you come to Gynae, you can see the future. This is a guy as well from Wits undergrad and doing a great job. So they managed to do surgery for that baby at 25 weeks, of which it was the first in Africa. And I think there's going to be more that is going to be done. So it shows the progression then of medicine, the progression of gynecology. So you can imagine. So guys, thank you so much. If anyone, not these guys, yeah. Thank you.
Right. Do I just press the middle button?
It's just loading.
But in future, I will press the middle button.
Correct, yeah.
Thanks, everyone, for coming. This is really easy for me, okay? And it should be easy for you. Yeah, thank you for having me at the Great Debate. And I'm here to argue for transplant surgery as being the Speciality Supreme. And you will see why. You sure it's the middle button?
Might be the right one.
The right.
Yeah.
Round one. So who am I? I am Francisca van der Schyff. I'm an abdominal transplant surgeon. And I've got a lot of papers on the wall, and eventually ended up being admitted as a fellow of the European Board of Transplant Surgeons. And I'm currently working at Wits Gordon Medical Center, and I do liver-in kidney transplants as well as living donor and deceased donor procurement, both in children and in adults. And if you can see on that list there, you'll see that I did everything properly. Real properly. And that is what is required if you're going to follow this specialty. Okay, top of the top of the top. There's no part-timers kind of chilling. Okay. What is transplant surgery? In its basic form, it's the surgical removal of a solid organ in end-stage failure and the replacement of that organ with a healthy graft. Sounds simple, right? But what does that mean? It is the most incredible job of them all. Hands down. Why? Because it's the only job where you can take something from a person that has died and put it into a dying patient to prolong life. That's a real God and Adam moment there. Okay? You talk about God complex, can't beat that. Okay? When everyone else is lost, all the other specialties have lost, and the patient is dead, there's still life there if you know what to do. Okay. So I love those two quotes up there. The one, it kind of encapsulates what it's about. It says, after I die, if I'm buried, I will rot. If I'm burned, I will become ash. But if my body is donated, it will give life and happiness to many others. And then this quote from UNOS, that's the American Organ Sharing Network. Without the organ donor, there is no story, no hope, no transplant. But when there is an organ donor, life springs from death, sorrow turns to hope, and a terrible loss becomes a gift. So how did I end up here? Road less traveled for sure. Okay, started off with general surgery. And then I got recruited into the Department of Pediatric Surgery. And children are the most vulnerable members of our society. And in state, they required a lot of care, and the department was imploding. So I went there happily. For 2 years of my life, worked my ass off, and helped a lot of children. But then I came across these ones, and they really touched me. Okay, these are babies that are born without bile ducts, right? And they're born normal. And they have normal personalities, and the family gets to bond with them, and they live until the time that they turn 6 months, and then things go wrong. They become jaundiced, they develop ascites, they develop varices, they become confused, and then they vomit and bleed and vomit blood until they're dead. And all of these children, there's only one cure for this problem. And in all of these children, what's sitting next to the child? The parent, who would give their lives for their child. A willing, living donor that would do anything to save their child's life. And what do you need? Skill. You need to know how to do it. And dedication. And what do you end up with? A baby I transplanted with a piece of liver from her mother. That is her mother. That is day 2 after a liver transplant. One of the biggest operations that you can do. On her mother's lap, alive, with a normal life expectancy. Okay, beat that. Tough.
But the guy needs a neutral. Missed it.
So what does a day look like? What sort of stuff do you occupy yourself with? You know, this vast majority of time that you're going to spend at work. What do you spend it on when you're a transplant surgeon? What is a day in the life of a transplant surgeon? Well, you're going to be involved with accepting the gift of life when you take a deceased donor's organs, okay? You will facilitate the most extraordinary sacrifice of a healthy human being lying on an operating table, willing to be cut open to save someone else's life, okay? That's living donation. And then you will be there when death becomes life. When you put that organ in and you sew it in, and you take the clamps off and it goes pink, and it starts making bile, and it starts making urine, and that organ lives, and your patient will live. And you will truly be at the pinnacle of surgical expertise. Trust me. There's very, very few operations technically more difficult than a living donor liver transplant in a small baby, technically variant graft, done under extreme time pressure. Because if you don't perfuse that graft in time, it dies, and your patient will die with it, because the old liver is already out. Okay. Sorry, just put me back there. Okay, shall I click forward? And whilst doing all of this, you will navigate the most profound ethical challenges that anybody else will face. And I'll touch on that a little bit later. You ask the real questions about why are we here, what makes you who you are, when should we stop doing what we're doing, and how do we maintain human dignity. All of that's part of transplantation. And then you will define the future, because you are part of an almost sci-fi, Frankensteinish specialty that takes something from dead people and make other people live. And the technology that's behind that at the moment is staggering. We're talking xenotransplantation, organ printing, pumping organs out of the body, genetically engineering them, auto-transplanting organs. That is the future of transplantation. It will define medicine and what it would look like in the future. Yeah, that's my introduction. Thank you.
Not a dry eye in the audience. What Fran doesn't want me to tell you is that the first successful transplant was done by a man called Joseph Murray. And he was, you guessed it, a plastic surgeon. All right. He saw the light. Okay. So finally, the talk we've all been waiting for. Plastic and reconstructive surgery. That's me. I didn't want to put every single degree I've ever done because no one can compete with Fran. So that's just my little one at the bottom there. Alrighty, let's begin. So, is plastic surgery the best specialty? Yes, it is. You all know it, and I think that's all I need to say. So thank you very much. Okay, so who am I? I'm Alex Diakakis. I'm a Witsie through and through. I've been here since 2007 when I started here in undergrad. I think most of you were still in utero, being operated on by gynaes. They came finally, they arrived. I always wanted to do plastic surgery. I did my elective in 5th year in the States with a Witsie as well, another one of our fine institutions graduates who's doing amazing things overseas. Briefly, I finished in 2012. I was a Barra intern, cleaning up the surgical pit. Then I was a Klerksdorp ComServe as well, Klerksdorp Tepong, great place. I did 3 years of general surgery where we all stitched hearts. It's not such a big deal. And then I finally did 4 years of plastic surgery, and I've got, I think, 6 days left of my plastics reg time. Yeah, whoop, whoop. And yeah, thank you. I finished my exams. I did my exams beginning of this year. Okay, so I'm a good Greek boy, so I'm going to have to tell you it comes from the Greek word. It means plastike, which means to mold or shape. So in other words, plastic surgery is the art of recreating or reshaping tissue that are either malformed or lost. And this is Fran beat me to the quote thing, but I'm going to do a quote anyway. This is a beautiful quote, and it's by Gaspare Tagliacozzi, who was one of the he was a surgeon. In those days, there were no subspecs in Italy in the 16th century, and it says that we restore, rebuild, and make those parts whole, which nature hath given, but fortune hath taken away. Not so much that it might delight the eye, but that it may buoy up the spirit and help the mind of the afflicted. And reconstructive surgery is a nice little thing there, is where art meets medicine. I think that's very true. So when the trauma surgeons are amputating things in the field, we're actually, giving people a life back. Anyway, so it's not all boobs and butts. It's a lot of boobs and butts, but it's not all boobs and butts. We reconstruct everything from head to toe. We do cosmetic surgery. We do aesthetics. We fix kiddies' faces, and we do make boobs bigger. Okay, so these are some of my cases that I've done during my reg time. So that guy on the left was a lower lip SCC who had a total lip excision and part of the right cheek as well. That's his forearm, and that's a unit of tissue based on the radial artery. And using that and doing a free flap, I recreated his cheek and his lower lip. And so the trauma surgeon would have been like, I saved his life, and I sent him home with a giant hole in his face. And at least now he can eat again. Don't know what happened to my mic. And I mean, if that's not the most handsome little dude you've ever seen with those giant eyes looking at you, born with a unilateral complete cleft lip, and that's a little cleft lip repair. And I think there's no arguing all the good work that everyone does. We save lives, we save brains. I mean, he made it such a meal. It's one organ, dude. One organ. Anyway, how many lives? We're all here because we had a gynecologist bring us into the world, and we all cried during Fran's speech. So I can't say much, but it's pretty special to give this little dude a life looking like a normal kiddie. He can walk down the street and people don't call him a monster. So that's pretty cool. We also do some less, life-saving stuff. We make lips poutier and sexier. And then we also, if you're 23 years old and have very, very big breasts and they're very uncomfortable and very sore and you hate the way you look in clothes, we can do some really beautiful work and give her life back, giving her self-confidence back. She can go out and live her best life. So it is cosmetic, but it's also really cool. This is pretty cool. This lady had a leiomyosarcoma of the floor of mouth, and the max fax made a giant hole in her face, and we had to kind of close it up. And if you notice, she's wearing the same little top that she was wearing pre-op, and that was the day before she went home with a, unfortunately, I can't show her eyes, I don't have permission, but with a big smile on her face and a reconstructed face. So it's, you know, we may not be saving lives out in the field, but we're giving people their lives back. And if you think back to Tagliacozi's thing about buoying the spirit and giving people a hope for the future, that's pretty cool. Okay, this is obviously not my work, but these are some of the other things we do. This is a very famous plastic surgeon from Sweden, Dr. Byrne. And I mean, that's pretty awesome. I mean, the girl on the left was 46 and now she's 19, and that's one operation. That's pretty cool. This is one of the gods of plastic surgery, Rod Rohrich, and his rhinoplasties, and how, you know, doing an operation on a nose can completely change an entire face and change that girl's life, because now she's confident, she gets to go out, and it's also just really pretty, so that's cool. And then this is another genius in our field, Andrew Gqola, who works in Manhattan. And that's a mother-daughter picture on the left-hand side. No, that's a facelift. That's just a facelift. That's all it is. And that's a young girl who's very beautiful, but aging a bit too early. And I mean, look at that. That's. I mean, you can drain a brain, but can you do that? Anyway, so why is plastic surgery the best specialty? Well, number one, I'm asleep when all these guys are still in the hospital, so that's beautiful. We do the most beautiful, most fine, most phenomenal. We fix babies' faces, but we also save marriages. This guy, Andrew Gqola, charges $100,000 for a facelift. So that's more than any of us make in a year. We operate on every part of the body from head to toe. No 2 days are the same in plastic surgery. Every day is a challenge. Every day is new. Every day is cool, no matter what you're doing. And we are the most talented and best looking of the group. So final thoughts. Bodhi, if you were to suture a wound, what forceps would you ask for? A Gillies forceps. Okay, Harold Gillies, a plastic surgeon. And if I asked Siseko, if you wanted to use a pair of scissors to cut soft tissue, what scissor would you use? No, but really the Mackindor, hey? Okay, yeah, of course he's going to use a Mayo, fine. Archibald Mackindor, a surgeon. So if it wasn't for us, none of you would be in business. That's it. Thanks very much.
Hectic. Right, I think we had... the range, I'd say, of the tear jerking to the bloodbath. Right, so I think we'll move on swiftly to the second round. Keep the energy up, keep the energy going. All right, so in this round, round two, we encourage the speakers to go into more detail about their speciality. The themes for this round are advancements and special cases in their represented speciality. Advancements include, but are not limited to, personal advancements in the field, exciting research being conducted, and the future of the speciality. Special cases could also include your most difficult case, your most interesting case, your most rewarding case, be it however you define rewarding, and your most emotional case. They could choose any that they did want. It was in the email. Anyway, moving on, I think we will continue the same order if that's all right with the speakers. So take it away, Dr. Haji-Joannou.
All right, are we up?
The computer is feeling the pressure.
All right, we're going to have to go all the way to round two.
Recap.
Yeah, recap. Basically, we're awesome. And we don't look at that. All right. All right, round two, fight. Let's go. All right. Let's start with the advancements. Okay, neurosurgery. You can see our boyki there. Actually, I don't Yeah, let's ignore him. Anyway, so our young man here, Elon Musk, as you know, most of you know, he's created his own company, Neuralink. And we know that neurosurgery is now heading up now, essentially this brain-computer interfaces that's currently now in research now. And in fact, there's actually some great advancements with regard to this. Unfortunately, now I don't think we have internet access, etc. now to get control of this. But essentially, we are now leading to the point in the future now where our brain can control robots. We are now able for paraplegic, quadriplegic patients now to control robotic arms and allow them to feed themselves. And this is neurosurgery. All right. There's more than this. There's functional electrical stimulation, the ability to send impulses to specific nerves and allow for those muscle groups to work and function. Also aids fantastically in rehabilitation. And let's not forget exoskeleton. You can become your own Optimus Prime. And essentially, once again, now in Japan, they have this fantastic hull suit, which essentially for our quadriplegic patients, they essentially now have the ability to control the thing. And now they're also trying to link this up now with the brain. All right. And then moving away from in terms of robotics, microsurgery is a massive thing with regards to neurosurgery, and we're moving away from that. We're now looking at things like our exoscopes. We don't need, we don't necessarily need microscopes anymore, and especially for all of our future, most probably some of you play Call of Duty, Fortnite, etc. 360 no scopes, yeah, yeet. Now we're looking for you guys. Come join us, join the robotic revolution. All right, and with regard to robotics, there's further, advancements with regards to our stereotactic biopsies. Essentially, we use CT scans, our neuronavigation, and now we can eliminate human error, and we can just get robots to do the job for us. And we even we're progressing now to endoscopic and minimally invasive surgery. So instead of opening the whole spine up there, we can do it through small little ports, and we can fixate the entire spine. We can repair essentially scoliosis, kyphosis, etc. And yeah, this is essentially now even progressing further to robotic spine surgery now with turning a 3-4 hour procedure into something like 30 to an hour. Okay, now let's get to the fun. All right. With regards to cases, obviously I can talk about the interesting, I can talk about the fantastic, the emotional, but yeah, I'm going to talk about all of it. All right. So this is the brain, something that trauma regists don't have. All right. So this is essentially a brain that you see post craniotomy. That's a patient had a subdural hemorrhage, essentially evacuated. That patient arrived with a GCS of 40. Do you know what GCS is? Okay, and essentially that patient walked out a few days later. All right, and now this is where the dirty comes in. All right, so this is where the importance of mannitol, phenytoin comes in. All right, we tell our trauma surgeons, put the head up for a reason, give phenytoin, give mannitol, because this is what can happen, transcranial herniation. Essentially, the brain swells up and it comes out of the head. All right. Not you. And then 6 weeks later, we can put a plate over there, making them all nice and fancy. All right. The other trauma, that's an extradural, just what it looks like before and after, and the massive cavity that's left behind. Essentially, the importance of decompression. Some fantastic spine cases, a patient with significant TB spine. Complicating now with quadriplegia. What we did, we went in fantastically, did our job, better than orthos, most probably. And essentially that patient's now in rehabilitation doing well. All right, and then let's not forget about our patients with C1, C2 disorders. And we've gone there and we placed in fantastic an OCJ fusion to allow for that junction to heal. All right. And let's not forget that we're also involved with, spine tumors. Or you can see on the right with our rongers, we're grabbing that tumor, and on the right, essentially a tumor-free spine. And then last but not least, no, not actually not last. This is not the last slide. We see the cerebellum. This is essentially a tumor. We're operating on a tumor of the brainstem. You can see that nice little web, which is the arachnoid, and then the brainstem just coming below that. And let's not forget that we're also vascular surgeons as well. So yeah, you can see a nice aneurysm being clipped. All right. And essentially, remember now the re-rupture rates, essentially patients are high risk of passing away, but a clip is 99% sure to prevent that, and a patient will live the rest of their life. Okay, this is my favorite case. Let's go. Plastics was not involved for this. That's one. So we have a young girl, that has a frontal encephalocele. All right. No, you'll see now. So this child was unfortunately, mom was scared of surgery for a while, and eventually she thought, let's bring my daughter in and let's sort her out. So we essentially took her into theater, and that's what we did. You can see the outcome. We have a little girl that now can see through her right eye. Unfortunately, her left eye was affected and essentially didn't grow from the encephalocele. But that is our work. Plastic surgery didn't want to get involved, by the way. All right. The other things that then, once again, neurosurgery doesn't always have to operate. We are our own endocrinologists. We work with pituitaries as well. Yeah, you can see that just with medical treatment, we've turned a pituitary apoplexy from something large and causing a patient to be completely blind to something small, and the patient now can see. And last but not least, the big boy. Craniopagus, conjoined twins. We are beasts. No one can do this besides neurosurgery. So you can see that on the right, last year, our team in UCT managed to essentially separate conjoined twins, and they are now growing very well. Just want to highlight a few things. One thing is transplant. You can't transplant a brain, can you? But I'm sure we'll have to be involved. So yeah. All right, that's me.
All pictures. Spoiler, it's just videos. Oh no. Oh no. Please have a video. Oh, nice. Okay, so kind of jumbled everything together. So I'm going to be going into talking about the day-to-day of a trauma surgeon in the second part. In the same way, and in the process, be showing you all the cool things that we get up to. So yeah, basically, we stab people back to life. So we obviously have a general surgery background, and it's all anatomical. Even in the age of ultrasound guided, which we're all proficient in using, if a patient like this on the right comes in, there's no time to get ultrasound guided, no time to get ENTs involved. You are the difference between this man living or choking to death on his own blood. So this is just a dig at transplant again. So obviously trauma surgery gets, I hope no one's squeamish. Huh? I assume no one is in a surge sucked. Hope not. So there's two outcomes really, right? So if we keep them alive, they don't need a transplant. And if we keep them alive and they have brainstem death, then they can go ahead and be a transplant candidate. Okay.
Brain test testing?
Yeah, I do. Okay, so things were supposed to come in. But like I said, when it comes to trauma surgery, you don't really have the luxury of waiting. So these are gunshot necks and faces. On the left there, that's an esophageal injury. You take these patients into theater, you're the difference between repairing it and saving the patient's life. And like I said, you can't always get the other suspects involved, so you're the ones that has to sort it out. So I'm surprised there's no orthos and cardiothoracics and neurology here as part of it, but that's a knife, as you can see, multiple knives in various parts of the human anatomy. We don't have cardiothoracics at Barra, so we're the ones that have to deal with this. And as Alex mentioned, yes, everyone has dealt with stab hearts, but we continue to do it because we enjoy it, right? So there's plating that we also do. This is a front room thoracotomy, which I'm sure you guys will get to see when you come through to Barra. So again, literally the difference between life and death. You make the decision then and there. You don't optimize the patients. You take them onto that resus trolley, you put in your lines, you cut that chest open, you stop the bleeding, you stabilize the patients, and then once they're stable, you then have the luxury of then taking them to theater to carry on with your management. But at the end of the day, Barra has, if you have a single ventricular stab, you have over 97% survival rates. So if anyone ever gets stabbed, those are your choose Barra or Mill Park, yeah. So just again, so I know everyone's going to mention, jack of all trades and master of none, but I beg to differ. We go from head to toe. Whatever the trauma is, whatever the insult or injury is, we're the first ones that have to deal with the insults. And whether it's a duodenal injury, which is normally catastrophic if not managed properly, to whatever small bowel injury, whatever liver injury you have, we're the first ones that have to get involved and have to deal with it. So the gentleman on the left, so he was on a motorbike and they got flung through barbed wire. And you had to resect all the necrotic bowel, you had to clean it, and I'll show you a picture later of what it looks like afterwards. And then you have bowel evisceration, so people that get stabbed, obviously you have a defect and your bowel loops through, you take the patient for theater, and again, you sort with it. You deal with the problem, we are the front line. Okay, a little dig at plastics. So sometimes you don't have the luxury of making it look pretty, but we also have elective theaters. We also take patients to theater. It's not always just emergencies and gunshot hearts and gunshot arteries or whatever it is. We have our own elective slates. We get to then decide if we want to fix the mess that we made earlier. So this is a ventral hernia that then we repaired with abdominoplasty later on while I was in trauma. Okay, so Tim deals with only vessels in the brain, which the radiologist, the interventional radiology essentially can do. And this is a surgical society debate, yeah. Whatever vessel gets injured below the angle of mandible, I suppose, we are the ones that have to deal with it. So that varies from primary repair to grafting the veins, using a saphenous vein graft, and making sure that their patient has a blood flow. Don't get graft rejection in this case. It does, occasionally. So these are carotid artery, carotid femoral, okay. And my gynae so we can all do B Lynch's, right?
I don't think so.
You know?
For that one.
Just to take a big stitch. But can you do a Reboa? No. So that's a endovascular balloon occlusion of the artery. So when there's bleeding that the gynaes can't control from a uterine artery and they're not on top of the bleeding, they called us to come stop the bleeding. So that, thank you. So that's another life saved by trauma surgery. I hope the video plays. I was supposed to. Wrong order.
Which video? This one.
Go for it. So that's a diaphragm. So I don't know. I'm sure you guys are all from different years, but eventually, when you do rotate through trauma, I'm sure you'll get to see a couple of stabbed hearts, frontal thoracotomies, diaphragmatic injuries. Below that, well, now this thing's in the. There we go. So, emergency room. So all of us will at some point, when we're done with internship, ComServe, have to get proficient with front room or emergency medicine. So we all know how to use ultrasounds. We know how to look. It's an EFAST, which you will learn. It's all things that some of the specialties that are here today are quite specialized and inaccessible to an extent. But all of you, at some point in your life, will have to have these skills. Okay. So an EFAST that's positive for blood around the hearts, and then that patient got taken to theater for thoracotomy. And that's a flail chest. So when you guys go through to trauma, you'll see, so if someone gets hit hard enough, so that's the paradoxical movement that they always talk about. So when you pass your trauma exams, it's my pleasure. Okay, so then again, back to all our vascular repairs that we do. So that's post-grafting, so that's a saphenous vein graft. Beautiful. It's a very satisfying feeling. Sometimes it takes a couple of hours and a couple of tries, but the patient's perfusing, and that's what counts, not bleeding out. And there's that heart that you guys love looking at. Okay, so apologies for the video. This is the only way I could get access to it. But so I know you hear about all sorts of traumas, so MVA, fall from heights, drowning. How about a combination of all three? So can you just play? Can you play this one? I'll just edit just to show. Just watch the green truck. The MVA, fall from heights, drowning. Patient came to Mill Park and was saved. So again, on the field kind of things that I was mentioning, right? So you get involved. Again, mad respect to all the specialties that are here. But if you want to get your hands down dirty, then, and that's the avenue that you want to pursue, then this is definitely the calling for you. Yeah, that's what it looked like. Okay, so as I mentioned, this is the guy that got thrown off a motorbike and then got flung into barbed wire. And this is him afterwards, leaving Barham. Doesn't look great. I'm sure plastics probably got involved, but what do they do about that? Nothing, right? That was us. Again, so that's on the field amputation. Yeah. So I don't know how plastics was going to fix that one. Let us know in your follow-up. And then in terms of people obviously tell you about the future of medicine and surgery is robotics and laparoscopic procedures. We do that too. Obviously, you don't have the luxury in dire situations to go laparoscopically, but if you have a patient that has a stabbed chest with a clotted hemothorax, you can just pop a camera in and just do a VATS for them. If it's not a severe injury, it's a simple stabbed abdomen, you can put in a camera, take a look, have some fun. Even if you're proficient enough and develop the skill, you can repair it. If not, and you find something that you can't repair with your laparoscopic skills, you can then convert to open. Okay, thank you so much for your time. And just remember, none of these specialties mark you, but you definitely rotate through trauma surgery. So I'll see you at exams.
Again, Dr. G, the guy again. Oh, but anyway, oh, that's me. But anyway, some of the stuff I think I'd spoken about in that other presentation. What I'll do, I don't have visual for the second round, but I'll discuss because there's so much to talk about. So when you look at motivational and most interesting cases that I think I've seen and closely been involved in it. One that I did mention was that of the surgery that was done at Mediclinic Morningside. So I won't go through that case again, but if you're looking at anything motivational or anything that it would be that case that I got to imagine, because what happens is that if you have amniotic fluid there, if you've got the womb, once you disturb that environment, it can be a needle, it can be whatever. So what these guys have shown us is that that environment, the environment that we once thought is the holy environment, no one must do anything. Patient might rupture membranes, patient might have an abruptio. They've gone in and done something and then taken a baby to term, which is at 39 weeks delivery. That baby is now, I think, 3 years now. It was in 2019. And the discussion then around a case that was quite emotional, that I think all of us will go through, is then having a patient and a family that, one, that is attacked by a very bad infection, that is a sexually transmitted infection, which is, we do fight with the surgeon sometimes of how do you make the diagnosis of it, which is a pelvic inflammatory disease. So I'll just put this picture there instead of my name there. Yeah. The future. Let me just put the future there, at least as a visual picture, not my name. I'm not the future, no. Yeah, something might happen to me as I walk out the door. But anyway, yeah. So this lady, they had, I think, 4 miscarriages as a couple. So you can imagine, you save so much money, you prepare, then their 5th pregnancy, then as specialists, then we start coming in now to assist this lady. We had realized when she came to our gynae clinic that she had bad tubal pathology, that what we call PID. So it had destroyed her tubes. So now, what do you do? What do you do when you got an individual that now you get there, you have to operate, tubes removed, and I think the one ovary had to be removed because of features of death and necrosis. So now this family wants a pregnancy. Then you look at that one ovary there on the other side, because all that family genetics and what is in that last ovary that is there, that you're looking and you're thinking it's probably infected. So then they needed assistance with a pregnancy, of which with the technology, with improvements that are happening, so IVF, we have to discuss IVF. This family needed an IVF. They get to have in vitro. First cycle, lost. So now this lady's been with these doctors for the 4 pregnancy. Now for the surgery that we're done, now we're attempting to put a pregnancy into that womb. They lose that pregnancy. It was on the 7th pregnancy that, and luckily, that 2 of those embryos that were inserted within that. I wish I had pictures so you can see 2 embryos there like the other guys, but sorry. They got twins. And you can imagine the celebrations. You can imagine the whole team was invited to the family event where celebrations. So you can imagine, guys, we are soft individuals. I think it's general surgeons say so much about us, peds, medicine, everyone. And then we go like, yeah. And it is those family moments that remind us again on what a great profession gynae is. And then again, other challenges, again, it's looking at tubal pathologies where you get what you call an ectopic pregnancy. I want people, even students, all of us, be aware in any sexual encounters that contraception, as well as having to plan your pregnancies, because they can be deadly. Case I was involved in, again, same thing. It can be a traumatic event, arrives, ruptured, unstable patient, abdomen full of blood. So what does that do? Probably not for tubal pathology though, but again, it means then us as being there, it's not only that you're gonna look at other areas of the body, it was that I'll talk about pregnancy because it's that emotional side to it. Again, it touches on that part that we need to have respect for our women. So I will just end it here. Thank you guys.
Wow, these guys have given me such great ammunition. Thanks, guys. Awesome. Right, round 2. We're going to finish this off, eh? There was a famous transplant surgeon who said, to understand organ transplantation is to understand all of modern medicine. And to practice organ transplantation is to comprehend the fundamental challenges of advanced healthcare delivery in general. That's a very broad statement, but I will give you evidence for that to follow. Transplantation asks the important questions. When exactly does life end? Okay? It was at the forefront of developing the whole concept of brain death. Okay? Are we more than a sum of our parts? If you can replace most of your parts, what makes you a sentient being? What exactly makes you you? And that's driven the discovery of MHC, it's your HLA that makes you you at a cellular level. Who deserves to live more? This is a question you ask every day. If you allocate a scarce organ, you are choosing someone to live and someone not to get that organ. When is the role of advanced medicine spent? When is enough enough? Right? Because transplantation can take you all the way. Anything that medicine can offer, you can apply to a transplant patient. And when is enough enough? Beneficence, right? What happens to patients who can't pay for the best care? If liver transplantation is the best care and your patient can't pay for it, what are you going to do about that? That's justice. How much sacrifice for a loved one can be allowed? If a parent will kill themselves on the table for their child, do you allow that? No, you can't, right? How do you balance autonomy? The patient can choose for himself to non-maleficence, do no harm. That's a question you ask with every living donor that you put on the table. A healthy person who does not need an operation, who cannot afford a single morbidity, let alone a mortality. What makes for a dignified death? How can you still do good when people have died? How do you preserve their dignity and still procure organs? So it asks difficult questions. Transplantation has molded modern medicine since the beginning of the 20th century, and many Nobel Prizes have been awarded to people in the field of transplantation. The birth of immunology, self-recognition, and allograft tolerance. What makes you tolerate a piece of meat in your body that doesn't belong to you? That science was developed by Peter Medawar, Frank Pillay, won the Nobel Prize. The birth of the vascular anastomosis, Alexis Carrel won a Nobel Prize for that. So anybody who does a vascular anastomosis has got a transplant surgeon to thank for that. The discovery of the self-antigen won a Nobel Prize. Treatment, pharmacologically, monoclonal antibodies, immunotherapy didn't exist before a transplant clinician thought of it. What about artificial organ support, dialysis, artificial liver support devices? ECMO was all developed to support a patient in end-stage organ failure to transplantation. Wouldn't it have existed without transplant? And then what is surgically possible? Living donor liver transplantation, dual transplantation, multivisceral transplantation, by far the most technically difficult operations you can do. And then infectious diseases, we see diseases that we saw last during the HIV pandemic, because these patients are immunosuppressed. Sorry, I think I do that to myself. And it has driven the development of antimicrobials, antifungals, because patients die on immunosuppression. So it has shaped where we are today. It has defined how we practice medicine at its core. Transplantation is inherently a team sport. It is not a lone ranger field. You have to work with the best in the field as a team. It's defined that concept from the start. Many people will claim to be team players. They are not. Okay. Your patient survival will depend on having the best minds in every field working together in transplant. It was from the start highly experimental. And therefore, it's been held to rigorous reporting standards. You can't do what you want. You do what you do, and you publish that in the public domain. You've got to answer for what you do with organs. You've got to answer for what you do to patients. Okay, transplantation started that. And if you have a very scarce resource like an organ, you've got to report what you do with that. So again, publishing outcomes in the public domain was started in the 50s by transplantation. And everybody else has since followed suit. And then this thought that, sure, we've saved the patient, he's alive, we've fixed him up, we've closed the holes, the inside on the inside. What now? Long-term rehabilitation, integration into society requires a transplant specialist to walk that road with the patient for life. And all of us should be involved in that. So in the end, all roads lead to transplant. Why do I say that? Because it is an absolute core aspect of almost all specialties. You can't call yourself an expert cardiologist, endocrinologist, gastroenterologist, intensivist, hepatologist, nephrologist, pediatrician, pulmonologist, surgeon, orthopedic surgeon, trauma surgeon, oncologist, and dare I say neurosurgeon, without understanding what role transplantation has in your field. Because that is the end game for everyone. It's replacing the organ at fault. And you can't do transplantation without having a very good understanding of all of those fields. Because if you put a patient in liver failure, every single one of those systems are diseased. And then you've got to do the most difficult operation on the sickest patient in multi-organ failure under pressure. And that's why I think it's fair to say that all roads lead to transplant. So, guys, coolest job of all. Really. You do some of the most difficult surgery on the sickest of patients under pressure. I get a kick out of that, okay? It is a fist fight to get into the field. You've got to prove yourself. Not all surgeons who qualify with a specialist qualification have got the hands to do this, and you will be relieved of your post should you fail to perform. So once you make it, you've made it, okay? It is the miracle of transferring life from a deceased donor to dying patients. That's what it boils down to. You, every day, are thinking very hard on what you're doing and what should you be doing. When is enough enough, and who deserves what? You will work with an awesome group of people. And why do I say that? Because nobody does transplant that's not in it heart and soul, who's dedicated their lives to the cause. Nobody there is a part-timer, not sure if he wants to come and help you, lying comfortably in bed, chilling. No. You are knee-deep in trouble in theatre. The whole team is there. The intensivist comes to check if you're okay. The pediatrician operating on a baby will be there helping you, putting up lines. Everyone does an all-nighter when there's a sick patient. It is the ultimate team sport and the team of the best. And you will be living on the cutting edge of medicine. Like I've said, you're talking organ printing. Imagine getting an organ off the shelf whenever you need it. Xenotransplantation, you know, they transplanted the first pig heart from a genetically modified pig into a human chest, and it worked for 2 months. Imagine living with a pig heart for 2 months, hearing that heartbeat, and you realize it's lived in a pig before. Machine perfusion, taking out organs, treating your sick organ outside of the body, and then putting it back. No need for immunosuppression. So genetic manipulation and autotransplantation is a big deal. And then, for me, one of the coolest things is you will be not one in a million. You'll be one of many millions. Transplantation has allowed me to be the only female on the African continent that can do a living donor liver transplant. And it is this field that's allowed it. This field has allowed that. Because if you are the best, there's room for you in transplantation. We'll get you there. So the others have made some mentions. Gynae, brother, not everyone should procreate. Huh? I'm just putting it out there. Trauma, in the field, you know, I'm on choppers, private planes, once a week, going out there to fetch organs, precious cargo. You want to feel like King Dingaling, you walk with a container saying human organ in the airport, and you see people just opening like the Red Sea around you. Roboa, have you seen what we do to deceased donors when we procure organs and we put them on ECMO, cardiothoracic ECMO? Makes Roboa look like you're plugging in a hose pipe. And what the trauma guys don't tell you, the vast majority of their work is open abdomens, fistulas, and bowel injuries. 80% of it. And I say that honestly, one of my best friends is a trauma surgeon, so I know. Neuro, I don't think your pictures inspired anyone. I think it looked pretty gory. But most of all, once you've opened this Pandora's box, the black box, nobody's the same. Your patient does not have the same quality of life long-term that a transplant patient has. Tim has left the building when you start cutting into that grey mass between the ears. Plastics, I'm all for looking pretty. I am. But when the real shit hits the fan, like we've got a pandemic, you know who disappears? Plastic surgeons. So let me end off with that. Transplantation is just way ahead on everything. We've defined where we come from. We've defined how we practice. We define where we're going. We define longevity. We will make people live 200 years if that's your choice, if your brain can stand it. And in the end, this is what you deal with every day. One of these two will get your organs. You decide. And you take something that would have gone into the bin, rotten in the ground or turned into ash, and you prolong a person's life, time with their family, time with their children, time to be a productive member of society, to contribute to our society and our country. And that's what transplantation is about. Thank you, everyone.
So deep. It's like such a horrible person to follow. My God. I should have followed neurosurgery. That would have been easy. So while we were, I was going to summarize. I'll summarize quickly. So in neurosurgery, if you decide to do neurosurgery, your job's going to get taken by a robot. Trauma surgery. Alexia told me to give a 4-minute talk, but if you'd like your logbook signed for your trauma lecture at the end, Bodhi will be at the front door and he can sign that off for you. Gynae, you're going to spend hours with your hand in a pussy pelvis, and then the robot's going to take your job. And then Fran is great, but effectively, you're going to have to be a priest before you can become a transplant surgeon, apparently. So don't forget to go to seminary school and then come back to medical school. All right, round 2. This thing is useless. Round 2. All right, there's round 2. So Bodhi gave you he distracted you with 1 million. This thing is useless. He distracted you with 1 million pictures. I'm just going to show you one picture. And Bodhi would tell you, bro, I amputated this in the field. And then I took a selfie and put it on Instagram to catfish. Okay. Whereas the plastic surgeon is going to bring you into hospital and stick this back on. And also the other thing about like stitching vessels, Fran said it to me quietly because I think she's a much better person than I am. It's very easy to stitch a hose pipe. Try and stitch a 1 millimeter vessel and then we can talk. Okay, so this is pretty cool. I mean, that has to be the greatest X-ray. That has to be the greatest X-ray of all time. The fact that it's not attached to anything is pretty awesome. All right, so this is a 46-year-old male who had a traumatic amputation of the distal forearm with a table saw. He presented 4 hours later, by which time Fran's liver is about 16 hours dead, and his hand was on ice. So what did we do? We rushed to theater. We debrided both stumps on either side. We had to plate the bones. We did the anastomosis, and I'll tell you about that. We did 2 arteries and 4 veins and 2 nerves. We quickly put the muscles together, and the hand was alive. It did take us about 14 hours. And everyone's going on and on about saving lives and whatever, but imagine getting to do beautiful surgery and the patient isn't actively trying to die. It's a dream. Okay, so will you play the video? So there's the team. I'm the fatty in the middle. There's the orthopods looking scared, as usual. And then here we are. There's the guys debriding the hand. It was pretty cool. So it was a pretty big team. So Fran's all about team. We have a pretty big, cool team too. There's me dissecting vein grafts, sorry. And that's where we started. Alrighty, so what we did was we stuck the hand back on, but obviously now this thing's not going to survive because it has no blood supply. So we need to give a blood supply. I don't know if any of you have seen a radial artery or an ulnar artery. The radial artery is about 1.5 to 2 millimeters, and the ulnar artery is about 1 millimeter. So now you're going to have to find a way to put a couple sutures into that. So we do microanastomoses. The problem is that when this hand comes off, especially in a table saw, everything gets absolutely destroyed. So there's a giant gap between the radial artery on this side and the radial artery on this side. So what we have to do is harvest vein grafts. So that means to do 2 arteries and 4 veins, you have to do 14 microsurgical anastomoses that are all less than 2 millimeters. So I think Fran, how many anastomoses do you do in the liver? like 6. 4 versus 14. And my patient isn't actively trying to die. Okay, so there we go. To give you an idea, that is a microsurgical anastomosis, and that is an artery, and each little line there is 1 millimeter. And if you look at all those little sutures, that's what we put in under the microscope. So now, I'm sure all of you in your Wits Surgical Society have done like the little, what's it called, the suturing course, and have tried to stitch like a banana together. Now, try to suture, put 9 to 12 sutures in a 1 millimeter artery, 14 times, make it work, and then we can talk. So there we go. We brought the muscles together and we covered them with a little skin graft because everyone thinks all we do is skin graft. So we did a skin graft. Yay. And there you go. 14 hours later, we've got a little bit of blood flow on the tip of that finger. And if you don't believe me, Fran stole the Frankenstein thing earlier, but I'm using Frankenstein again. Just like Frankenstein's monster, we went from this to it's alive. And this was a video that the patient sent us 10 weeks later, and there he is. And this wasn't done by this, thank you, don't clap for me. This wasn't, dude, this wasn't done by people with, I think Fran has 68 degrees. This was done by two senior registrars here at Wits, no consultant. We did it ourselves, and his hand is moving. So is plastic surgery the coolest? It is, I know.
Awesome. I think we really had, once again, a very good breadth of topics, and I hope that none of you watching at home have had your parents walking in for those more gruesome moments, but we'll hear on the Insta later all the complaints. Speaking of complaints, what the viewers at home don't know is that next door we have our wonderful catering from Olives and Plates. So we're going to be cutting to intermission, commercial break in a moment. And so if everyone would not mind, the speakers can head first. They will get first dibs. We do have Olives and Plates, and we have provided our own wine. So if you are driving, and I know that some of you are probably driving, do not have the wine. We are not responsible for said things. However, otherwise, we will cut break, and we will see you in roughly 20 minutes. So stay tuned. Awesome. Awesome. So I'm going to be turning this mic off in a second because we are going to be using the studio microphone. So all of you listening at home, it does get a bit quiet. We are still figuring out how we can best optimize the IT in this room. So I'm going to be turning this mic off so that I'm the same volume as the rest of the speakers here, and we will be, these little things on the ceiling will be capturing us. So put on your headphones, put up the volume, and let's get this party started. All right, so we're going to move on to round 3, which is some short questions. We get all the specialties up in a row and let them have a bit of a chat. And yeah, so we just have some general questions that we'll get through to just kind of get the vibe going, and then we'll open to some questions from the audience. So think of what you want to hear, and let's start. So I think the first question that we have is, if you couldn't do the speciality that you were doing, what would you be doing instead, and why? So here I
In order.
Just start at the end.
Go Timothy. No. Go Timothy.
Yeah, we can just go in order. Yeah.
Sure.
Neurosurgeons take time to process things.
That's actually, wow. Actually, no, that's actually, because I think my professor's right now is listening to this. Wow.
So one day.
Bad time to play.
I choose neurology. Wait for it. I'll tell you why. No, the reason why.
No.
Actually, I don't even know why now. The brain is the best thing in the world. Okay, let's just go straight to it.
When it works.
When it works. You're here because of your brain. You're
Yes,
smart
exactly.
because of your, right?
Not to be tampered with.
can't be tampered with. It's something that, when damaged,
your
is
job
irreversible.
description is tamper with the brain.
So I'd say I'd go towards neurology, you know, try and work up the patients.
Yeah.
And then-
If not surgery, surgery adjacent.
Yeah.
All right. That's Dr. Fred.
I would definitely cut in every life after this one. I would choose to cut. And probably the most vulnerable, so pediatric surgery. I almost became a pediatric surgeon, very close. Fine technical work, clean surgery, good outcomes. Yeah.
Oh, I hate following Fran. She stole my thunder. Yeah, yes, definitely. Finesse. It's all small, it's all beautiful, it's all gentle. You have to be very exact. Except they're sick as well, so not for me.
So we'll have a ped surgeon at the next great debate. Watch for 2023.
Yeah.
Right.
They will win.
So it's another surgical specialty.
Anything. While we
So, yeah, agreed. So definitely cutting. You can't stay. I was gonna go with stay-at-home husband. That's
House husband.
House husband.
Home executive.
Since we're sticking to surgical work, Dominic, there's a beauty with cutting and working with your hands and seeing things as you work with it. You see the results straight after, which I don't know in the medical fields, maybe not as much. So definitely surgical. So if not trauma, since I'm representing trauma, then HPB because it's very technical, good. Not always the greatest outcomes, but. I'll tell you straight up.
They all die.
It's not all. But technically,
All die.
They need a transplant.
Yeah, they all go to France
yeah,
for
it's something
transplant.
there. And, I just want to say it without saying transplant. HPB would be better for me.
It would have been pediatrics.
No, pediatrics.
I actually, in my community service rotation, I had to choose between doing obstetrics or gynecology and pediatrics. So I did 6 months of ONG, then did 6 months of pediatrics, and then it was the neonatology department where we had to the drips. And then I said no, thank you, but yeah, it will be pediatrics.
Okay, awesome. So on the opposite side of the spectrum, I've heard from a lot of doctors now that sometimes you find out not what you want to do, but what you absolutely don't want to do, and you kind of narrow down your decision from there. So what, probably more surgery, could you not see yourself doing at all, and why?
General surgery, done.
Fair enough.
Without a doubt, like I said, and you've seen my bio and all of that, sewage pipes. You're working with poo. Have aspirations.
So when you get stabbed in the abdomen,
Aspirations, not gastric aspirations. Right.
Just in defense of general surgery, since I'm a general surgeon before I became a transplant surgeon, it does lead to great things. Plastic surgery,
Plastic surgery.
transplant surgery. It is the core training of becoming a proper surgeon. And there are other things in the abdomen and in the neck that you operate on in your gyms, like the liver, the pancreas, the spleen, the thyroid, the parasites. Yeah, just in defense. But what I would not do, probably if I go to hell, Satan will tell me that you are a physician. Be honest with yourself. Prescribe. We call physicians magicians because they prescribe little tablets and then wait 3 days for it to work. And then we Google the differential. And we have intellectual masturbation about what it could be. It's just too protracted. Either you do it, you don't, and the patient lives and gets better, or he dies, and that's it. You go home and you know you've done something, or you have missed it. That's just me.
Sorry to Fizz Sock. Anyways, moving on.
Do we have to say surgical or can be anything?
Anything, I guess.
Anything, okay. Pediatrics. Physicians, but with screaming people. No. Physicians and crying. No, absolutely not. Absolutely not. Peds was the worst 4 months of my life as an intern. Never again.
Dr. Shaw.
if I had to pick out of the surgical, probably orthopedics.
Oh!
Someone's upset.
You are number one.
I've been told my whole life I look like an orthopod.
Yes.
But I think, you'll see, when you do internship, and it's often department to department that kind of influences a department to you. So when I did internship at Tygerberg, the orthopedics department, the exposure that I got was not great. So it's crazy. A lot of the decisions that influence your life going forward just depends on, it was 3 months or a week in a certain rotation. So for me, unfortunately, with orthos, I was looking forward to it, but then I didn't find it as intriguing or
The real reason, is because the only place that everyone else was buffer than he was, so that's why.
And just a fun fact: what is long, pink, and hard in an author's hand? ECG.
The real reason you've all seen the asystole videos, right?
Yes.
About
and then also, urology as well as So I'll throw in urology as well. No go.
Yes, it will be definitely psychiatry and neurosurgery.
Not neurosurgery. It's the opposite side.
Psychiatry.
Yeah, it's too far away.
I see why you chose to sit all the way there. All right. So in a similar vein, but not for yourself, as a practicing surgeon in your field, what would you say is your least favorite specialty to consult with, work with?
That is
What's, you asked for spicy. I'm giving you spicy. Let's get some answers here.
Pediatrics. I feel, I'm gonna get ripped apart.
The baby fixers.
I feel that a lot of our pediatric patients come in, unfortunately, towards the terminal end of their life. And I feel that pediatrics a lot of times make decisions that essentially throw these children's lives away when there's a chance. And I've encountered this. I'm not saying every pediatrician is like this, but we do find this in many institutions. And children are children. We give them a chance. We're there for them. And it's just it's just not nice when someone that's not in your field makes a decision that a patient is not viable for not candidate for ICU, not viable for life. So we've got deep right now.
No, fair. I mean, for anyone who is thinking of that, I mean that's something to consider, I guess. Well, it's So, Dr. Brand.
I think practically orthopods, mostly because I cannot get them to understand what I'm saying. It's not a patient that's got sepsis in a joint, and the patient's on immunosuppression, he's going to die of sepsis. They just will not do what you know any reasonable person will do. And you can't argue with them. There's no penetration information. I'm sorry. But, I'm sorry, neurosurgeons are difficult in my world because they sit on the source of the window. And they're so reluctant to declare brain death and tell the family what's going on. Not shy, but in general. I mean, really, there are many people out there lying in an ICU as we speak, brain dead. The neurosurgeon won't declare it. They'll rather wait for cardiac arrest than to get the transplant removed. And that is really because of my patients are dying. So I have personally visited about 15 neurosurgeons in Johannesburg in their offices saying, please, some reasonable.
Definitely, some are reasonable.
We'll finish this out back. Neurosurgeon versus.
But I know Tim will not be.
Dr. Diakakis.
Oh man, I can't say the orthopods because they give me so much work. You have to be nice to the orthopods.
Can't bite the hand that feeds you.
Exactly. Who do I not like interacting with? I don't know physicians. The physicians are so painful, and they just physicians.
Long-winded.
Oh.
No end inside.
No physicians. Like honestly, your entire here's another beta blocker. We'll see you in 2 minutes. Physicians.
All right.
We're not talking about intensivists here.
Yeah.
Those are a different breed to a physician.
No, I'm saying good one.
Let's not bring that.
We know what Bodhi's is because Bodhi made it quite clear on his Instagram story who he wants to fight with the most. So that was spicy.
So yeah, it's a neurosurgery because it feels like so I don't want to just like jump on the bandwagon, but it is, and Tim's my best friend. So I went in with a really great impression because he did neurosurgery, and then I just got disappointed time after time dealing with neurosurgeons because not for neurosurgical intervention, if they just like basic looking after patients, like they deny it and they try as much as they can to just bat patients. So I find that in the surgical discipline, it's neurosurgery that gynae, because they call, just to address that.
There's one fight.
Just to address my spine.
Just to address it, yeah.
I was ready to say
Sorry, guys, but you.
general surgery.
But you can't, if you can open an abdomen and your uterus is right there by all the bowel, how can you not suture it if you've perfed it? Like, part of it is to look, you have to look for the ureter, how many inches ureters, right?
I'm coming.
Sorry. So
We need to separate these two.
like when I'm on call at Helen Joseph, and then at 3 a.m. it's like Rahima Musa's calling. I'm like, now I have to drive, risk my life to go repair your bowel perf. Or the last time I got called to release adhesions. Like, if you're gonna be in that space, you should know how to use.
Dominic, you know my enemy already. You know my enemy already.
We'll need a trauma surgeon after this.
So, for me, general surgeons, the most disrespect you ever get. And you could hear it. And like, my colleague come, bro. Can we? Like, no. How can you get into that abdomen? But you can't. So, no, basically, I need you now. And then the other team will be an anesthetist. And it will be, it's always based on that we want to do a certain intervention and we're requesting, can you just put this patient in a situation that I'll be able to do my job, and it's like, you don't have this. Have you done this one? No. I have to coffee time. Then I have to cancel. So yes, general surgeons and anesthetists, the worst in the hospital.
Anesthetist problem is private.
Yes, exactly.
Because
We become clients. Yeah, we become clients. Yeah, we become clients. No, but general surgeons, please, can they change their mood to us, guys, please?
The poor guy hasn't slept for 3 days. All right. Okay, I think to make it a bit more serious, a bit more academic now. Well, not academic. Let's put it that way. All right. So another question we got is, what was the biggest hurdle that you have had to overcome in your specialty, or in order to get into your specialty? What is the biggest hurdle, sacrifices that you've made?
Biggest hurdle, sacrifice. Sure.
Hard-hitting questions at Search Song.
Yeah, granted. It's actually deep. I guess the problem with neurosurgery is that you don't get, you don't really get exposure to it as much in medical school. Internship, if you're lucky to go to some department, you might rotate and you get exposure, speak to a neurosurgeon. So you'll never ever really get to know, what is neurosurgery truly about. Do I want to do it in the future? If you are going to throw yourself into something like that, you have to be prepared for essentially hard work. We are a department that is growing significantly. Trauma is expanding. Unfortunately, there's a lot of resource issues.
Why are there no rotations happening there in the early years? I always wanted to know.
And I feel that,
it's true that it affects how we make, as you had said, how we make our decisions, having to choose. Because if we had done rotations earlier and we had met the team, then it changes your mindset on. I wonder why.
And you got to be prepared for those things. In neurosurgery we have a go-to, especially with Barra, Charlotte. There's no such thing as
neurosurgical.
There's no such thing as post-call and all of that. You have to prepare to throw that, that away. You will work 5 cases through the night. You will go the next day and you'll do an 8-hour procedure. You'll come home at 8 o'clock at night, get ready for the next call the next day. So you have to be ready to throw away. I'm going to be very honest. The biggest hurdle in most things in life, especially when you're doing big things like this, is your social life, your relationships. These are things that you have to consider. So like these are very deep issues. So if you are willing to take that sacrifice early, if there's someone else in your life that's willing to be there for you and to get go with you through that, and I guess
bonus.
I guess that is a bonus. But I think that's more those are just some of the hurdles that you see. Like you're tired most of the time. And yeah, I guess that's it. But I mean, the reward at the end of the day is, you know, for me, you get to save a brain. And yeah.
Thanks, Dr. Phil.
I think for me, it's been an absolute biggest challenge of my life, and it will always be this way. It's how to look after the well-being of my children versus that of my patients. So I'm happily married. Don't ask me where I found them. We were children, essentially. We grew up together, and we've got 2 girls. And they are not delinquents. They're not drug addicts and not in prison. But that is tough. Juggling, having your children cared for, loved, and for them to grow and prosper, versus a dying patient in the hospital. That balance is the toughest thing by far. I think choosing your partner wisely, I would recommend. Have a partner with any traditional ideas, steer clear. That's for men and women. I think you need a wife as well that's very open-minded, very liberal, kind of willing to accept challenges and believe in your dream. They are on board with your dream. Everyone's doing transplant surgery in the family. It's not just me. That's what we always say. So I think that issue for me was a big deal. And being pregnant and operating stuff. Because you're competing with the men. They didn't impregnate you. Hopefully not. And you being pregnant and putting a load on the system when they're already fatigued and pulling that card, I think is a bit low, to be honest. I think if you choose to have children while doing this job, you must take your punishment. And then I would do it this way every time in my lifetime. I have children and do it, but I don't blame anyone else for it. I don't ask for special favors. I want to be the best and compete with the men, and for that you need to earn it.
But you compete very well, though. Like the ladies are like,
I'm not sure if it's a competition anymore.
they do so well. 4 years on time. Babies on time.
Tune in to Women in Medicine next week. Brought to you by SurgeSoc in collaboration with a bunch of other societies. Thank you for that.
Amazing, nice plug. I agree with everyone here. I'm going to answer it in a slightly different way. And my answer would be that I think if you're going to pursue, you will be able to get to wherever you want to get to. It might take you longer, it might take you shorter. You'll get there in the end. But I think if you want to be excellent at something and you want to be the best, it has to be your passion. And maybe that's what I would say. I think the hurdle is that the sacrifices need to be worth it. Because there will be sacrifices, I agree with the other two. And I think that it has to be your passion, it has to be your focus. If it's not your passion, your focus, there's easier ways of making money. There's easier ways of being a doctor. There's easier ways of affecting lives. You don't have to be a transplant surgeon to save lives. There's lots of other ways that are simpler and easier and much less difficult for you and for your family. So I think pursue what is your dream, and if it is your dream, it'll be worthwhile. If it's not your dream, then relook at the decision you make. Because I think it gets to a point where it's not. And then you might get it. You might become a plastic surgeon. You might become not a transplant surgeon. You might become whatever. It doesn't matter. But you're not going to do it justice, and it will not do you justice unless you give it your 100%. So it has to be everything for that little space of time until you can prioritize other things.
I think, well, everyone's mentioned, gone to the crux of the thing is that as a surgeon, you have to learn all the theory and then go and master a craft at the same time and be able to perform it day in, day out. So it's a lot more than just what physicians do. You can't just study, right? You can't go home, read a textbook, and then go the next day and then do transplants.
You can't play golf at 11.
Yeah, exactly. And for me, the
Hoppest one if you're a plastic surgeon.
So for me, the biggest hurdle has been getting a balance. And then you realize you're a person you try to be someone else outside of it. But fundamentally, if you're going to be a surgeon, it's going to be part of your identity. You take your patients home with you. I have patients phoning me, asking about things. I give patients, family members my number. And you sometimes you regret it, but because you get a lot of unnecessary phone calls at random times, but it does come home with you. So yes, you need an environment where the people surrounding you encourage it or support it. And then you also have hobbies, and you also want to go out. And you just have to, for me, the biggest thing is, and where I've made the most peace, is being comfortable that the only thing I can sacrifice if I want to get everything else is sleep. It'll probably catch up in a couple of years, but I'm happy with what I do because I will still go home, and if I have to play video games, I have to go out with my friends, I'll do it. But knowing well that, okay, I've got 4 hours of sleep, and I'm going to have to make do with it.
How many hours a day do you allocate just for selfies? asking for a friend.
Breather.
15, 20 minutes.
Fair enough. Yeah, for me, truly it's the rotation. It truly presses on the reminder that I missed home. Started in Cape Town, undergrad. Then I come to Johannesburg. So then what I realized that I thought that now the 6 years is done. It's like, oh, now it's working, it's fun time. But then it was another. So if you're looking at internship, Costa, then you do 4-year rotation. So that's another more than the 6 years that. So then I realized that it's true that like my life is, because now I'm already looking into another subspecialty. So it takes so much away from you. I think it's the rotation itself. It's too much. I think it's too much, but it's important. But it takes away, as the other speakers have mentioned, that it takes away so much of your time and it makes it very tough. So I'm a farmer back home, so then I get to miss those opportunities. But you miss events, like serious events. You can't, because there's this exam, there's that exam. It never ends here, guys. There's another exam. It's forever, as she said now, with already European society. And they're going to be pressing her because she wants to be now the chair of that society. So it never ends. So I feel the rotation, it takes so much of your life.
Awesome. So I think we'll wrap up with one thing. I think, Sudarshan, if you can get your timer out, we'll do what I would like to call a minute to win it. So final statements. Because right after this, Peter will explain how we're going to do the votes, and we're going to decide who gets this lovely prize package over here that Priyanka will give us all the details about all our lovely sponsors and what they've given the lucky winner. So I think Sudarshan, if you can start the timer, maybe do like a 30 seconds So why should you be the winner leaving this evening? So just say go when you're ready.
Go. Because I'm a gynae. Guys. Procreation, I'm telling you. All of you guys have to be here. So it means we have a huge responsibility, and I need to be a winner because I think you guys enjoyed, you laughed, and we had a great fun. Thank you so much.
Yes, we're all winners here tonight. We're in the business in trauma surgery, we're in the business of saving lives. That's period. That's about it. There's not much else to it. Jack of all trades, master of all, and Need I say more?
Find out.
Okay, plastic surgery. I can't argue with Fran that I think transplant surgery is the pinnacle of general surgery, but plastic surgery is a pinnacle in itself. You have to have beautiful hands, you have to have a beautiful eye. Your patients aren't dying, which is lovely because you get to take time to make things perfect. You have to be compassionate with cancer cases, you have to be patient with cosmetic cases, you have to be a perfectionist, and then when you're done being a perfectionist, you have to be even more perfect. It's beautiful, it's amazing, and it's been my dream my whole life, and if any of you think it could be your dream, nothing is more rewarding and more awesome.
So you get more compliments. You look good. Thank you, doctor.
Whose team are you on? I've got one vote. Come on. Get in.
I think transplantation surgery is the best of everything. involved with the most profound existential questions that being human entails when you are dead and when you are alive, and how can we get more time with our loved ones. And it's just, it awes me every single time I put an organ into a person and blood flows into that organ and it lives while it was dead on ice. Nothing can beat it. It's just, and these patients become part of your family. They become part of your life story. You never ever forget a transplant patient later, and certainly don't forget you. And every anniversary of that transplant, we get cake and parties, and children grow up, they go to school, they have their own children, and your family and your life experience grows every transplant you transplant. And that from something that would have gone to ground, to waste.
I think for the next great debate, we'll get some tissues to pass around. Under your seats, you will find. All right.
All right. So we're neurosurgery.
Yeah, the time.
So yeah, granted we might seem like a one system, department. But the brain is more than just what we think it is, right? It is the most intricate organ that there is ever. From allowing you to see who your love, allowing you to develop as you are, your personality is your brain, allowing you to walk and touch and feel and all of that. There's nothing more beautiful than that organ right there. And when there is pathology of that, neurosurgery, we are there to try and reverse and try and make, to keep that from progressing worse. So I don't know. There's nothing more. I think there's nothing more beautiful than that. Opening up and seeing the the connect. The beauty of a brain, the cortex, the vessels. I'm just waffling right now, but there's nothing more beautiful than that. I don't know how to explain it, but yeah. Can't really say more.
Yeah. Well, we hope that waffle was delicious. So I think we will now move on to the voting portion. I think Peter, if you'd like to come up and explain, and the rest of you make your decision.
Are we allowed to vote for ourselves? Absolutely.
In case I get zero.
I've got 2 votes. I've got 2 votes. I've got 2 votes. Come on. Alan got Silas and Tara's votes. I've got 3. Not 2. I said Sarah.
No votes.
I changed it.
All right.
I'll take over your
Please, be gentle.
Right, so tonight you have heard from 5 incredible speakers representing 5 equally incredible specialities. And over the course of the evening, they tried to convince you that their speciality is indeed better than the rest. So in a moment, we will activate a voting channel that will be open for exactly 5 minutes. So we'll put up a QR code on the screen and you'll be able to scan it and vote. And a nice song so you can have fun. So every person will have, online and in person,
I gave him my phone.
will have 1 vote, and that vote cannot be changed.
So I think this. On that note, you guys can go and sit. We're probably going to wait a bit more time just to account for our friends watching at home. We will send some messages on our on the class group and such. Maybe we'll see. You can do your own campaigning. Thank you very much. We have our own marketing department. Maybe if you had a marketing department of your own, you could do that. All right. So without further ado, go take your seats, and we will wait patiently. Debate amongst yourselves while you make the votes. All right.
We are gonna do it.
You voting for yourself? No.
Vote for you. You're voting.
Good evening. That goes both to our viewers here and those watching online. I'm Priyanka Amrithlal. I'm the head of sponsorship and public relations for the society. I think it's fitting that I take this time to thank our partners and sponsors for each of their contributions. I mean, I'm proud to announce that this year the prize for the winner is bigger and better than ever before in the Great Debate history. You know, without the sponsors and of course without my hard work and excellent negotiation, this wouldn't have been possible. So our first sponsor is Greens Medi. They are South Africa's first and favorite customizable scrub brand. They also plant a tree for every 100 scrubs sold. So perhaps a good initiative there. Our second sponsor is WardWorks, which some of you may be familiar with. They've sponsored hampers for each of the speakers, as well as for 3 lucky viewers tonight. The WardWorks app is basically a free and POPI compliant app that is designed for patient list and task management. It's designed by doctors, of course, for doctors, so perhaps relevant to us in that matter. Lastly, we have a message tonight from Dr. Coffee, who's asked me to read it out to you. So Dr. Coffee is a new and weekly podcast designed for junior doctors, so that includes MOs and interns, as well as for medical students in South Africa. The weekly episodes feature senior registrars and consultants in a variety of subspecs and disciplines to share their journey in medicine. There are also episodes about med students regarding matters on how to apply for internship, study skills, how to survive med school, exam stress, and a whole lot more. So episodes are uploaded weekly. That is on Apple Podcasts as well as Spotify. And he encourages you guys to follow his Instagram page. That's Dr. Coffee ZA as well. So with that being said, let us continue to spin the wheel. And that's going to be for 2 lucky viewers here in person tonight, as well as 1 online viewer. Each winner will take home a hamper from WardWorks, as well as a pair of Green Medi scrubs. Are we ready?
Spin the wheel.
That is the brand.
It's a Haji.
Green Medi. I don't know what kind.
The winner.
The green.
They're customizable, so you get a voucher to choose what. This winner. Antonia, are you present here today? Oh. Unfortunately, it is only eligible to members, to viewers who stay the duration of the event. Okay. Okay, Tehran, are you in person?
Oh, I think, you know what?
Okay, come.
Tehran lost it. It's fine, he got
As long as it's not neurosurgery.
No. Our department's watching.
In the wheel. He's winning the lottery. No. I know now we've won. Now you know how to win.
That does conclude our in-person winners. This is an online winner, and then we move to the winner of the great debate. Just viewers. Okay, so online viewers, Elizabeth. Congratulations.
That's also celebrating
Now we progress to the reason we are here tonight, and that is the winner of the great debate. So our winner tonight will take home a pair of Greens Medi scrubs, as well as a pair of scrubs by Wardworks, as well as a 500 Rand Motherland coffee voucher sponsored by Dr. Coffee.
On-call people.
And not forgetting, of course, this very sexy trophy with his name engraved in it.
No, your name will be engraved on the trophy. Third Stock's budget is not that high, sorry. If you'd like to sponsor a trophy next year, by all means.
Without further ado, I'd like to call upon Dominic to announce the winner for the evening. Thank you.
All right. Now for the time. Now for the time we have all been waiting for. That's why we're here. So the person that is going to be what? Oh goodness. Okay, great. Kids, are we going live? I'm going to be live on YouTube and Instagram. Are we on all your platforms? Who's on TikTok? Yeah. What's happening? All right. So we got we got in a total of 80 votes, I'd say, and so it was a good portion. I think they got what's the percentage?
Check. 32%.
32% of the votes. This it was very close. The first and what was the second?
28.6.
We'll be announcing the second place after the event on Instagram. So stay on our Instagram and follow us if you want to find out. Subscribe for part 2. All right. So. Can we get a bit of a drum roll, please? And the winner is Transplant Surgery.
Thank you, guys. This is really awesome. But all jokes aside, I said a lot of things about the other guys, but to be honest, gynaes, I almost became a gynecologist because really, that is serious business, delivering healthy children. Trauma, come now, guys. Young people who make mistakes, you bring them back to life. The brain, the enigma, the thing none of us have decoded. So yeah, I get you. And then plastics, reconstructing big holes. If you've got a hole in your face, got a hole in your perineum, you can't live. You don't want to live. And you need someone to fix it. So thanks, guys. You guys were great competition. And thanks for the votes.
Awesome. So yeah, I think to finish up, I think we're all winners here except the ones who aren't. So All right, so it's been a pleasure having you all here. It's been a pleasure hosting this evening. It's been a pleasure having everyone. I'm going to hand over to Nadia to do the thank yous, and after that, we do have some more catering, some more wine. Come back, come chat, come cry on our shoulders. Our shoulders are big. We can take it. We're orthos. Right. So without further ado, thank you and good night, Nadia.